Really? Oh, good job.
That was a lot of whatever that was, popping, cracking.
Adjusting.
Yeah.
We'll call it that. Hey everyone, Dr. Todd from Gonstead Spinal Wellness. Today we're going to go through a workup of Emily. Emily's actually a new team member here at our clinic, and she has a history of horrible chronic back pain that started after injuries of lifting other patients. She's worked in healthcare, so we're going to see if we can help her. We're going to go through a consultation, an exam, x-ray, and then hopefully we find that she's a candidate for what we do and we can adjust her, and we're going to capture this all for you so you can see the process. Before we get started, make sure you subscribe to our channel, like this, put some comments below, share this with other people who you think this may be helpful for. And keep in mind, we serve two different audiences. We take care of our public and people that just want to learn about natural health and healing and how to stay healthy for a lifetime. And the second audience that we serve are chiropractors. We teach chiropractors how to put functional movement and corrective exercise into their chiropractic practice, kind of like this sort of stuff that I'm standing behind right here. This is our exercise area. You'll see some information below to find out more about what we do. So with that said, let's get rolling. Emily, so tell me, you have an ongoing low back issue.
Yeah.
That you've had for how long?
3 years, but 2 years of consistent pain.
So what happened 3 years ago?
That's an awesome question. I worked at the vet's home, and I hurt my back at some point over there, but it was like a pain that would only come every now and then. And then when I started at St. Luke's, it's when it got consistent, where it was like every other day, then it became like every day.
And this is from lifting people, right?
Lifting,
right?
bending, twisting. I've done like the whole 9 yards. So that's why I can't like pinpoint exactly like.
Sure.
It was probably, the amount of patients I picked up off the floor.
Okay. So it wasn't like a singular event. It was. So 3 years ago, this started. Prior to 3 years ago, no issues with your low back?
Nope.
And tell me your history of sports, athletics, that sort of thing.
I did basketball for a couple of years before I grew, and then I grew really fast. And then I did cross country for 6 years, all the way from 7th grade through high school. And I had problems with my knees, my knees and my hips, but that was because I think I was not running the proper way. I didn't have the right form. And it was just growing pain, so I wasn't too worried about it. Okay.
Are you still have any issues with your hips and knees?
Yeah, my hips will lock up, or my right hip will lock up when I'm driving sometimes. Or if I'm in a certain position, or my hips flex at a certain length, it'll cramp up and lock up here. So when I'm driving, if I'm driving for too long, my hip, I can feel it cramping, and so I have to move my leg over because I can't move it.
Okay, and it's actually in the hip that you feel
it? Yeah, it's up in here, the hip joint up here. I've had to pull over a few times and stand up, get out of my car because it hurts a lot.
Okay. So right hip's an issue, primarily though your low back, and right in the center of your low back.
Yep.
Right.
Right on the sides of the spine, and then if it gets really bad, it will travel up the spine, up into my neck. It's not often that my neck hurts, but it's mainly just my back. And then if it gets really, really bad, I get really nauseous and I get numbness and tingling down in my right leg only.
How often?
Actually, I just had an episode a couple weeks ago. I went and tried to help one of my residents, and I did the proper body mechanics. Instead of bending with my back, I was trying to lift with my legs, but we didn't have enough momentum that my leg kind of slipped out from under me, and I moved my leg and my back went at the same time, and it just flared up really bad.
How long did that last for?
The tingling lasted a couple hours, the numbness lasted about 24. It's the numbness that'll usually last a little bit longer, especially if my sciatic nerve flares up, then it's about 48.
Okay, and does it go away on its own, or are you taking medication when it happens?
When it gets that way, I take naproxen, which is they gave me prescription strength Aleve, and then I'll take a muscle relaxer. I only take that if it gets super bad, and then I get off of it.
And again, how old are you?
22.
So you're 22 years old and you're taking some high strength anti-inflammatory stuff.
Yeah, and I only take Aleve if I'm getting to the point where I have to get off my feet, because I can deal with back, if I'm having back pain, I can walk around, but if it gets really bad, then there's times where I'll have to like physically get the pressure off my feet.
Okay.
And that's when I'll take the pain medication because it'll just go from there.
So what we'll do is gather other parts of the history. I wanna start with this. I wanna get back and do an exam and focus on this main issue. The goal is to find out what's the cause of the problem.
Okay.
And then actually, hopefully we can fix the cause of the problem so that you're not going from 22 and going on 60.
Yeah.
You know, because this is not a good way to start off in life as far as being 22 years old and already having chronic pain. Right? You'd probably agree?
Yep. I'm kind of over it sometimes.
Yeah, I don't blame you.
Like I can only drive for like half hour, I can only drive for like half hours before I'm like, I have to start like moving my back. So if I can avoid driving, I do. Because like when I'm in the car, I can usually try and like, if I'm in the passenger, I can at least try and move and get the pressure off my back, or I can put something. And I've done this a few times where I've actually put something, because sometimes pressure will just relieve it.
Yeah, if you push yourself forward.
Yeah, I'll push myself forward and I'll actually like kind of sit on a golf ball and just kind of roll back.
So question 2, have you been to a chiropractor before?
No, you'd be my first.
Okay.
I've done 2 rounds of physical therapy.
And how did that work for you?
Yeah, the pain's still there. And I do the exercises when I'm at home, like in the mornings, but it's...
Well, let's explain what we're going to look at that's going to be different than what you've done before, okay? So first off, and this is stuff that you may know, but I'll explain it so that you can hear it at least from a standpoint of how we look at things. So this is the front of the spine, this is the back of the spine. You have a bone, disc, bone, nerve in between, spinal cord down the middle. With trauma, the bones can shift backwards out of alignment. That's called a subluxation. So it's kind of like a dislocation, but smaller. So a small little shift is all it takes to cause the joints to swell. Okay. So the swelling can happen at the disc. There's multiple ligaments in here that can swell and stretch and cause pain. And ultimately, if there's irritation to a nerve, then you'll have stuff like numbness, coldness, weakness, some of the things that you just listed, right? So this is called a subluxation. The reason that this matters so much is because of how it relates to your overall health. This is even bigger than just having back pain and difficulty driving and difficulty getting through your day. It affects overall health processes. So here's how this works. Your brain controls everything in your body by sending energy down through your spinal cord, okay? That energy then comes out through the nerves, connects to the organs. So your organs out here and really everywhere is dependent on the energy in your spinal cord to keep you alive and healthy. So if you have a subluxation, let's say down here in the low back, that acts like a dimmer switch on the wall. It turns the energy down. It can't get through from the spine out through the nerves into the organs. And the organs will weaken, degenerate, even create a disease process out here. So over time, this stuff can really wear down when it starts as what is perceived as just a back injury. And this is how it works in your entire spine. So we're going to focus not just on your low back, we're going to look at anything and everything else that we find. Fortunately, in this method of chiropractic and what we look for, we have a very objective way of finding things, meaning you either have it or you don't. Okay, so like we're going to go through, we're going to look, do you have swelling? Do you have restriction in a joint? Do you have a change in temperature on the surface of the skin? These are all things that give us clues as far as where the problem could be. And if you have a problem, then we figure out, can we improve it? Can we help fix it? And that's done by exam, done by x-ray, everything that we're about to do to figure it out. Okay? And then hopefully we'll find out that this is going to be a good solution for you and we can start to get on the road of getting you to recover and
I have a set of
rehab.
x-rays from when I got them done, but she said there was nothing on there, so I'm like, okay.
Yeah, and that's going to be also a good, interesting take for you to learn about as well, is that in the medical world, when they look at an x-ray, they're looking at, is there a fracture, dislocation, pathology? Okay, or like something really major that just screams at you. Well, you're 22 years old, so how much arthritic change is going to be there? I mean, in some cases we see 20-year-olds and there already is arthritis, but if there's not, they're going to say you have a clean bill of health and they're going to check it off. The problem is you don't find the problem on the x-ray, you find the problem on the patient, and then the x-ray tells you how to fix it once we find it on you. So that's where they unfortunately just have this a little wrong, is that they just say, oh, you have pain, let's look at a study, Don't see anything, must all be in your head. Take some anti-inflammatories. It's just inflammation, get over it. And then the anti-inflammatories stop working, then you start going into like opioid medication, and that's why we have the crisis in our country today with so many people hooked on opioids.
I don't like taking the naproxen if I don't have to, because I don't want because I'm already used to, I used to take ibuprofen and Tylenol for my head, for my headaches all the time. And now my body's used to it, so I don't want my body to get used to it.
So are you having headaches currently too?
Yeah, I always think it's from dehydration though, because I'm really bad with drinking water.
It's probably not. It's probably from a problem in your neck or irritation to a nerve. It likely is, and you've just kind of convinced yourself and rationalized that it's dehydration.
Every time I have a headache, my parents are like, "Did you drink enough water?" I'm like, "Probably not." So you're right. That ProTech machine though looks really comfortable, because David put like one of the guys in there the other day, and I'm like, that actually looks really fun.
Yeah, and that might be something that you're a candidate for. It's that for first and foremost, what we do with all of our patients is we look to see, do you have a segmental problem in your spine? That's the core of what we do here in this clinic. That's what makes this so different, is this method called Gonstead, which is why why our clinic's called Gonstead Spine and Wellness. It's how we find and how we fix a subluxation. That is the thing that is at the root cause of this. It's kind of like probably the best analogy, I'll say this, and then we can get up and we can move and start examining you, is like if I took a big rock and I smashed it on your foot, and that rock is sitting on your foot, and your foot is dysfunctional and it hurts and it doesn't feel good, until you move that rock off of your foot, anything that you do to your foot, how effective do you think it's gonna be?
Nothing.
It's not gonna be all that effective, right? So you can massage it, you can hook up electrical stimulation, you can take some drugs to make it feel a little bit better, but you gotta roll the rock off the foot. That's the analogy to if you have a segmental problem in your spine. Until we actually find and adjust that level of the spine, anything and everything else you do is gonna be short-lived or just somewhat effective, but not fully effective. And so hopefully that's what we find with you.
Yeah, that'd be nice.
That's what I'm hoping to find for you. Okay, so let's go back to exam, we'll get the ball rolling.
We
Go from there.
finally find a problem for it, because we can't figure it out.
Yeah, or a solution for the problem, right? So you need a gown, probably.
One of those.
Yeah, I mean, you could fit into this, it'll be too short for you.
Yeah.
So, all right, come on back. So we're gonna head on in here. And this is already all set up for you. Perfect. Okay, good. All right, so if you want, I'll step out so you can change, and all you have to do, pants are fine, shoes can come off, everything from the waist up comes off, gown opens up in the back, and earrings come out too, if you can take those out.
Okay.
And as soon as you're ready,
Do you want that out?
no, you can keep that. And as soon as you're ready, just crack the door. Okay. All right. So let me give this to you. So how this works, this little instrument measures temperature on the surface of the skin.
Okay.
And if it gives me a reading, it tells me where there could be a problem.
Okay.
And if I find something, I'll make a little mark on you, and you get to watch the process, which is kind of cool. So I'm gonna go over the same area several times. And if there's anything you feel as I go over the area, you can let me know too. Like if an area is sensitive or sore, sometimes you'll feel it, sometimes you won't feel anything. And I'm looking for a reproducible reading, so I'm just going over the same area multiple times. Doing my best to not get tangled up in your hair too. Nothing too reproducible. There's a little flicker up top that might be something, but I'll investigate when I palpate, meaning when I check for abnormal or normal movement in your neck. So that's the next step, is I'll move your neck around and get an idea of how stuff's moving in there. Okay. All right, well, you have a little something in your lower neck to begin with. And that can have a pretty big correlation with headaches. Most things that we see that are neck related that can cause headaches, it kind of depends on what part of the head the headache is located in, which I didn't ask you that in the consultation. Where do you feel the headaches when you have them?
Sides. It just kind of depends too. So like I can feel it at all points. A lot of the times it's my front and the sides.
Okay, so more frontal or more by the eyes is usually lower cervical. More suboccipital up here is usually upper. And you're saying you feel it more to the front of the head?
Yeah.
Okay. Yeah, that would typically be more of a lower cervical, lower neck.
Yeah, if I'm getting
origin.
a migraine, it's usually I can really feel it on the sides.
Yeah,
Kind of.
and a true migraine too is usually lower cervical, and interestingly enough, from a visceral or an organ standpoint, you know, that whole thing that I was talking about is as far as how nerves control organs and glands and that sort of thing, lower neck is to the thyroid.
Interesting. I do have thyroid issues.
Okay. Well, I'm gonna dive into the rest of that when we go through your full history and we get everything. I did a abridged version so we can get back here and start checking you. So what kind of thyroid problems do you have?
What was it? They weren't too worried about it because apparently my levels weren't too high, but.
So hyperthyroid?
Yeah, I had a really active thyroid that I couldn't put on weight for anything. My lowest I think in high school was 110, and at 6 feet tall, that's nowhere near I need to be. I think I was during the summer, right before cross country hit, I was able to get up in close to 120, and then as soon as I started running,
you just ran it off?
Yep, because it's just, I was also, I can eat, but I don't eat enough calories, and I've even tried to put myself, not on a diet, but increase my calorie intake, and it just, if I eat too much, I just end up throwing it up. So I listen to my body now, and if it's hungry, it's hungry.
So it's hard to force feed yourself to gain weight.
Yeah.
Yeah.
So I don't eat, I hate eating in the mornings, especially right after I wake up. So my body's gotten used to, I'll eat those P3 protein packs. I'll eat something small in the mornings so I can have something, but I usually don't eat till afternoon.
Are you around 120 now then?
No, I'm in the 150s now.
Oh, 150, okay. Yeah, I was gonna say, I didn't think you'd be 120 right now.
No, I've put on weight the last 2 years.
Okay, well that's good. Well, looks like a good healthy weight for you.
Yep, I'm no longer, what is it, my BMI is up to par now, I guess.
Okay, so here's the culprit as far as the main complaint as far as your low back is concerned. You have a pretty consistent reading right down at the belt line, right? Your lumbosacral spine. I'm gonna pull this down a little bit so I can go into your sacrum too. See if there's anything there. So there's L5-ish.
Does it matter which way the gauge moves?
Not necessarily. It's more of a deflection at that level of the spine is as far as what it's telling us is that something's up at that level. And then from there, I'm going to investigate further by mostly palpating for edema. So I'm feeling for swelling. I'm checking movement. Hopefully my hands aren't too cold. They're usually warmed up by now, but you're my first person I'm seeing today, so. Cold hands, warm heart. That's what my mom said. All right, so that's your SI joint. You're jumping a little bit.
Yeah.
Is it pretty uncomfortable in there?
Yep. Yep, right there too.
How's this guy? That's 5.
That's uncomfortable. Yep.
And that's down on sacrum. Is it worse on one spot? So watch, this is, let me just see, I'm gonna put my hand on your ilium. 4, that's 5, so L5. S1, S2.
S2 is definitely.
S3.
Okay, the S's are definitely not.
S4. That's really low on your sacrum. It's not as bad down there, is it?
No.
So
Like
S3 and 2 is where it starts.
Yeah.
Okay. And then comparatively to your fifth lumbar, would you say 5 is better or worse?
Better than the other ones.
Okay. All right. So 5, 4, 3, 2, 1, 12, 11. A little funky at 11.
Mm-hmm.
That's right where you had a reading too, and there's edema in there. So what it feels like to me is it feels like a bruise on an apple. It's a really subtle little indentation, or it feels mushy around that spinous process. Mm-hmm. So I'm feeling the bony prominence of your spine, and I'm trying to feel the tissue surrounding there, and I'm comparing it to the nearby tissue.
Gotcha.
And so when something feels different, which is mostly like this little boggy feeling, mm-hmm. that's when usually it's tender on your end, and I'm marking it further with a skin marking pencil, because then the next step is I'm going to tape BBs on the spots that I find so they show up on the x-ray. Okay. So on the x-ray it'll be like a little white dot. Okay. We can correlate that to where we have the exam findings. And that's how we do the initial workup. So we have a good starting point. You know, even in the past you said you had some x-rays of your spine. You probably had sectional x-rays, I'm guessing. So you probably had like a sectional low back x-ray, maybe a neck x-ray.
Yeah, I think they did a low back and then like a full spine.
Oh, did they?
Yeah.
So maybe like to rule out a scoliosis since you're a tall female. Yeah, scoliosis is more prevalent in females, and especially when someone's taller.
Couldn't you feel like when I think of scoliosis? Can't you feel it like if like someone's standing up?
All depends on what degree the scoliosis is, and oftentimes it does a really good job hiding. Mm. So if someone knows what to look for on posture, it might give you some clue. It's something that we spot a mile away typically, but a lot of times it's missed in other cases, and taking a full spine x-ray is the definitive way of figuring it out. Mm-hmm. Now are you sensitive to the touch, or are you just jumpy?
I'm just jumpy.
Okay.
Because I don't have people that touch my back all the time, so I'm like, oh.
Just kind of a vulnerable, protected area.
Yeah.
Okay. That's 7. That's 1. You're pretty locked up on both. 7 and 1 are both not fantastic. Let me check your upper neck. Put your hands in your lap, like palm up, just to get your shoulders to relax. Perfect. I'm going to tip you side to side. Okay, I'm going to stand behind you and check something. And tip you side to side. Yeah, you're worse going left. Left atlas, you feel that right there? Mm-hmm. Bend your head down. So when you bend your head down, it locks the lower neck and it isolates the upper neck, so I can check rotation. So I'm going to rotate you. And we're going to rotate you. You definitely right rotate a lot more. Mm-hmm. So ASLA. So what that means is that your atlas, very likely, and we'll confirm on x-ray, has gone anterior superior. That's the most common way it goes. AS, misaligned to the left, and then it's rotated forward. And by it be rotating forward, when I bend your head down and I rotate your head this way, you go further this way because it's already rotated forward that way to begin with. It's already misaligned forward that way. When you try to rotate back this way, it doesn't want to go as far because it's misaligned forward on the left. Dang. So the atlas is a ring. It's a circular bone. It's very different than the rest of the spine. But that's what this bending and rotation thing does, is it helps isolate atlas rotation. So I can at least assess that one area, because the majority of rotation in your neck comes from this upper joint, not from the lower joints. So when someone's restricted in rotation, if it's not just a muscular thing, if it's joint restriction, it's coming from up here.
Okay.
Okay. So, and this is a cool part of this system of what we do. It's a very objective, step by step figuring out what's going on. This is what unfortunately is a lost in a lot of methods of chiropractic, is the analysis part. Mm-hmm. Most types of chiropractic are, hey, come in, where does it hurt? Get on the table, crack, 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 let's move stuff around. This is very heavy in the analysis to figure out what's going on, and then with laser-like precision, we say, it's that one, and that's where we're gonna start. Mm-hmm. And we start very specifically.
I always thought chiropractic work was the videos I see though. Is like when they're in that certain position and then they press on them and then they just, like everything just cracks all in one.
Yeah, there's a lot of, thanks to YouTube now, there's a lot of videos out there, and that's part of the reason that we're making videos, is to try to present a different side of how this works, that there's like a lot of specificity and precision in what we do.
Mm-hmm.
And it's a different flavor of chiropractic that a lot of people aren't really exposed to. And then in this clinic, not only are we doing Gonstead, but also the second method in traction, spine remodeling, that's chiropractic biophysics. That's very specific, lots of research behind it, taking pre and post x-rays, changing posture, showing it, proving it on x-ray. And then the functional movement component is then addressing, measuring movement and fixing faulty movement. So it's segment, posture, movement. So it's addressing all three of those things. So it gets pretty involved, it's pretty in-depth, but it's, at this point I would never practice any other way. So we got 11, fifth lumbar, possibly 1, 2, 1, 2, 3, 4, 5, 4. Both of those are funky.
Yep.
How's 6?
Not as bad as the other two.
We're gonna say 5 is the winner. All right, I'm gonna tape some BBs on you.
Okay.
And how we do this, we take these bigger BBs, we tape those on the spots where I have a finding, okay? And then we take smaller BBs, like from BB gun BBs, and we put those on little freckles and moles and that sort of thing as landmarks.
Okay.
So that when the x-ray pops up, we can say, oh, there's a mole there, that's at the level of T4.
Okay.
And so it helps confirm our palpation. It helps make sure that we're accurate in our count. Let me have you stand up. I want to look at your posture real quick. I'm just going to have you stand facing that wall. I'm going to stand behind you. I'll look at a couple things. Why don't you come closer, Linda, and stand right here and then get like a bird's eye view. Okay, so you're slightly right rotated in the pelvis. The pelvis rotates back this way just barely. So that's not too concerning. Let me look at, I'm looking at leg length. I'm gonna put my hands in the back of your pelvis. There's actually one more thing I want to check. I didn't check your SI joint. All right, this left shoulder is quite a bit elevated compared to the right. That's pretty noticeable. I don't know if you ever noticed that. But yeah, you're quite a bit jacked up on this side and lowered on this side. And then slight increased thoracic curve here on the side view. And then your head, C2, should line up over C7. Watch, tuck your chin and pull your head back. Yeah, so that right there would be vertical alignment. Probably feels a little weird.
Yeah.
Yeah, so that's actually where you should be. And then relax, and then that's where you're at. And then these shoulders, just check, the shoulders are moving, but they're both definitely sitting in a forward posture. All right, and then,
When I stand, I do put a lot of pressure either like on my heels or the like front of my feet.
yeah, and it looks like your left side, something I'm noticing on the left side, I'm looking at the angle of your Achilles tendon back here. And so as your calf comes down into your Achilles, this Achilles tendon should go straight into your calcaneus.
Yeah.
And there's a pretty big angle here on this left side, more so than on the right side, which shows that this part of your foot is tipped down and in, which is, I mean, really in simple terms, it's foot pronation. So the foot's flattened and dropped in.
Okay.
And it's happening more so at your heel on the left side than the right side. So there's some asymmetry in your feet too, as far as alignment. Let me check one more thing. Come on over here, have a seat. Feet on that bottom step again. And then you're gonna put your knees and your feet together. And you're gonna take your knees and you're gonna go out in with the knees. I'm gonna check how your SI joints are moving. So go ahead, bring your knees apart. Yep, and just move back and forth. Keep going. Keep going. Okay, go right side only. Okay, again. And then left side only. Again. Again. Right side. Yeah, you're definitely more stuck on the right. So there's an issue with the right pelvis. We'll get all this stuff documented, but let's get you over to x-ray. So come on over here. I'm gonna have you stand here facing forward. You're gonna back up to the first part of your body touches. I'm gonna get you lined up at the bottom of your pelvis. Now we're going to do a bending x-ray of your neck to see what that looks like. See if you have normal movement patterns in your neck, and to assess for what's called a spinal ligament injury. This is all stuff we'll explain to you after we get the x-ray, but it's pretty telling. There's a lot of information you get from doing bending x-rays in the neck. So for this one, so especially with a history of headaches and whatnot, this is why we want to look at this. So the first thing we're going to do is I'm going to do a retraction x-ray. So you're gonna pull your head back. So tuck your chin back. Okay, let's get you to be a little more upright as much as you can. We're basically forcing you into a normal posture because I wanna see the pattern of what your neck does when we do this. So this, just like that. Hold still like that. Rock the double chin. Embrace the double chin. Going through and taking the 3 pictures that we took of you from the front and then overlapping them and
I have a curve in my spine?
and stitching it together. Yeah, a little bit.
Doctor never told me that.
So on these x-rays here, on the bending one, something that we'll have evaluated, we'll have these all marked up. What we're looking for is as you bend forward and back, ideally the bones in the neck or anywhere in the spine, when you bend forward, they should not slide forward. And when you bend backwards, they should not slide backwards. Mm-hmm. And there's a very small amount of tolerance or amount of movement that we allow and consider acceptable. If you add up how far it goes forward and you add up how far it goes backwards, it should be sub 1 millimeter. So it's a very small amount of movement. And there's certain guidelines that say if there's a certain amount of movement that we measure, it tells us how much of a sprain there is to the spinal ligaments, which this is a thing that gets unnoticed, undetected in so many traumas, especially when someone gets in a car wreck and they go into the hospital and they have a neck problem. They'll put them in a neck brace, they'll take an x-ray, they'll say everything's fine, and they'll tell them to go home with some painkillers. What they should do is, well, motion, but sometimes at that moment when they're in so much pain they can't, so it should be a couple days out, a week out. There should be a follow-up process to assess for a spinal ligament injury. Right now you have full mobility of your neck, so we can adequately measure this to see if you have it. This is something that we'll have blown up and measured, but it looks like 2, 3, 4, 5. Looks like your 5th cervical is sliding back on 6. So this one right here, the back of 5 compared to the back of 6, it's moving. Yeah. So there's some excessive motion there, and even this one right here, right above it, is shifted back compared to the one below. We'll measure it and quantify it, but it does look like it's quite a bit.
Wow.
Yeah. So Jenna sent these over. They'll pop up on the screen in the other room. You can keep your gown on. Let's go to the other room, and we'll pull your x-rays up, and we will.
Like, I didn't realize what was going on on an x-ray.
Yeah, as far as
when
structure.
You're pointing that out, I'm like, wait.
Yeah.
And then like seeing like the small like curve, that's new. Cause
Right.
I always feel my spine. I'm like, oh, it's straight.
Things off. Right. Sometimes seeing the x-ray is what helps start to put the pieces together, not just for us as the doctor, but as the patient.
Mm-hmm.
And that's such a powerful tool, and it's not just a tool to, you know, wow someone that something wrong, but there's a lot of clinical data we get off of there that drives how we adjust you, how we do exercise, how we do traction. Okay, so this is the side view of your spine. We'll have this all marked up and analyzed so we can explain more after we get it analyzed. But for right now, you should have a forward curve in the low back. You're flatter and straighter in the low back than we'd like to see, most likely. When we analyze this, we'll get the exact degrees. You should have a backward curve in the mid back, and it shifts back a bit excessive. And then you should have a forward curve in the neck. And this area, this is where you can see it most clearly. You have this backward curve, and it should transition into a nice forward neck curve. And can you see where it starts to transition and then it just stops right here?
Yeah, and then it kind of goes straight.
And then it just goes straight, right? Yeah. So the point in which it stops is naturally what catches our attention to say, what's going on with that level right there? And usually that's where things misalign. Like usually that's where a bone actually subluxates and misaligns and gets stuck. So on exam, when I just checked you, you were really stuck at C6 and C7. 2, 3, 4. Actually, sorry, that's 2, 3, 4, 5, 6. Yeah, that's 6 and 7. So yes, so 6 and 7. The BB that I put on there, let me see. This is where the BBs come in handy because sometimes some people, we think a bone is in one spot and then we find out, oh, we were one off. We counted off a little bit, especially with these taller spines like you. Sometimes it throws us off. So that little BB right there.
Is that the mole?
Yes, so 2, 3, 4, 5, 6, 7, 1, 2, 3. So in between 2 and 3 is that one right there. So that's this one right here. Bend your head down for me. So if this is, yeah, so this is 3, that's 2, that's 1, that's 7. And that's surprising because that's really not where I would think your C7 would be.
I thought it was more, is that the bony one?
Yeah, so on you, so watch, bend your head down a bit. That's 2, that's 3. So 3, 2, T1, C7 up here. Let me just see on the side view. We'll double check that. Yep, that one right there. 2, 3, 4, 5, 6, 7.
Really?
So that one's right on 7.
So this is C7?
This is, watch, let me show you. 2, 3, 4, 5, 6. Yes, this one right here is 7. And that's 1, 2, 3. Okay, so it's either 6 or 7 that we need to work on with you. I'm tempted to adjust 6. And then let me look at your AP again. AP stands for anterior to posterior. We take it anterior to posterior, so we take it from front to back. So it's called an AP, full spine.
Okay.
We look at it, P to A. We flip it around. So this is your left, this is your right.
Yeah.
So now we're looking at you as if we're standing behind you, which helps from a chiropractic standpoint because I'm looking at your spine here, I'm looking at your x-ray here. It all makes sense and lines up. So this one, based on the curve here, we need to be setting this with a right-sided contact because you're wedged open on this right side. So the vertebrae on the right side are opened up on the right side. You can see right here on the x-ray. These vertebrae right here are opened up on this side.
And they're closed on.
And they're closed down on this side.
Of the way, like, just because of how much it is?
It's pretty much because of the shape of this upper thoracic scoliosis, which is what this is. And then you compensate with a right head translation and a left lateral flexion, and you have this hard bend. So up here is what really needs to be addressed.
Yeah.
This is what is the innocent bystander right now. That's giving you problems, likely associated with the headaches. Okay. So this BB, so go ahead and put your feet out in front of you. Okay, so how this works is your first time ever getting adjusted. So I'm not gonna twist your neck at all. We're gonna set the bone forward.
Okay.
And the best thing you can do to help me is just try to relax. It'll probably make a little sound. And like I said, I'm not gonna twist you, we're just gonna set it forward.
Yeah.
Okay. And I'm gonna start at C7. So we're gonna bring this up. Good, good. Just be as loose as you can. Let it go. Lift your chin a little.
Oh.
Okay. Good.
What the? That was.
Okay.
That
And
was
so
weird.
that moved about 50% of how I want it to move, but that's probably all it's gonna do today. You're very locked up in that joint. We got some motion there. So now here's the deal.
That was so weird.
Yeah, it might be a little weird at first.
Yeah.
So now for someone like you who says, oh yeah, I pop and crack my back, if you ever do that with your neck, I guarantee you the segment I just worked on is not the one that's popping and clicking. It's so restricted and so locked up. Instead, the ones above it
Yeah, that's
are
where I
likely
feel
popping
it
and
the most,
clicking.
is, like when we were doing the X-rays, when I was like loosening, I would just kind of go back and forth, and
You'd feel excessive motion. Well, also on that X-ray that I showed you, where you're bending
Yeah.
and that bone's moving too much, which it looked like it was your 4th and 5th cervical. That's the stuff that's clicking and popping and moving too much. So the way you fix that is not you adjust those a bunch of times. You look for the areas that are not moving. And in your case, your 7th cervical was a good place to start. But with that said, it's going to take a few visits to get that to release set well. But this is a good start. It's your first time getting adjusted, so I don't want to overdo it with you. Okay. Come on up over here.
That was interesting.
Yeah, it's a little interesting. I'm gonna have you step on the black platform, face goes down on the paper. Table's gonna go flat. Hands can go, let me show you. Right there. All right. 1, 2, 3, 4, 5. Okay, drop your hands all the way to the floor. Just sink into the table. Are you comfortable enough here? Okay. 1, 2, 3, 4. 4 is the one that's wedged so badly here. That's 4. And that's 4. And then 5 is tender on you too. Honestly though, 4 is the one I'm gonna go after. 4,
Yeah, 4 is.
I think is the best starting point. I'm gonna set this. All right, so drop your shoulders down. Just sink into the table. Be as loose as you can. Try to drop this part of your body too, if you can. Is that okay on your low back, or does it hurt you? Okay, real loose. So sink this down. That already wants to move. We're just gonna set this easy. Good. Good.
Ooh.
All right. Okay, all right.
Damn.
I'm doing my best to make this.
That made me tear up.
Did it really?
Yeah.
I'm doing my best to make this a comfortable first adjustment, but the spots I'm working on are some really challenging spots. Here, you turn it up. Don't cry, Emily.
I'm not.
All right. And then this last one that we're gonna do in your low back,
It didn't even hurt. It was just like, whew.
a little intense.
Yeah.
Yeah, it's set. And again, even this one, set about 50% of where I want it. So I can tell you've been guarded.
Because I had a headache.
Oh, that's good.
So.
Cool. Well, one down. All right, let's set L5. Let me just look at this.
Did it just mirror my hips off too? Because
Yeah,
it's like the left,
slightly.
my left hip higher than my right.
Yeah, it looks like your right side's dropped a bit. Could be a slight leg length inequality, meaning like a short
That's what
leg.
we worked on in physical therapy was my right hip was always the weakest.
Was that? Maybe
Yeah.
come on over here. I'm gonna have you sit in the middle of the table facing me. And then you're gonna go ahead and lie on your side. You're gonna straighten your bottom leg, so bottom leg stays real straight. I'm gonna bend this top one. Bend this top. straighten this. Scoot towards me just a little bit. I won't drop you off the table.
No, you're good.
And even with this, I'm not gonna twist you. The goal is to set that vertebra forward.
Okay.
Let's pull this arm out a little bit. I'll pull this out and under. Good, right there. I'm gonna roll you into me. Roll, 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 good. Okay. So just like the rest, I'm making sure I'm on the right vertebra. So bottom of 3, 4, 5. Okay, you're gonna roll into me a bit. I got you pinned right there, you're not going anywhere. You okay? Okay, we're just gonna set this forward, just like this. Reel this. Oh, good job.
That was a lot of whatever that was, popping, cracking.
Adjusting.
Yeah.
We'll call it that. Okay. So get up nice and easy. Let's just see if you have any feedback on your low back. It might be something that feels different. It might feel completely the same because it might take a few times of setting it and getting the swelling down. But go ahead and stand up and just walk around a bit and see if there's any change.
I'll know a big change once I start like putting when
You start working.
Yeah.
Okay. All right. So then today, try the best you can. Stay as upright as you can. Try to catch yourself if you're failing, because flexion, and this is a really important thing to think. This is a thing that we teach our patients. I want you to be saying this to patients in traction too, so they understand this. And it gives you another understanding of what traction is doing, because traction is extension, right?
Yeah.
In exercise, we do a lot of extension training. So flexion is death and extension is life. That's the way I want you to think about it. So think about throughout the day, if you're doing this, you are in a dying, sick posture. You gotta get yourself upright. Be proud of how tall you are.
Is this gonna give me more height?
It could.
That's actually the only
Possibly.
thing I'm terrified of, because now I have to take my tinderbine off.
Yeah, I mean, technically, really, this flattening out will give you a little more height. Putting more of a curve here will shrink you down. Putting more of a curve here will shrink you down. I think it'll all level out and you'll be fine.
I was like, I do not want to end up 6'4", because I already have.
All right, so icing.
Okay.
This is what you should do right after you change here, is ice for a few minutes here in the clinic. Normally go 20 minutes on, 40 minutes off at home, 2 to 3 times a day if someone's real inflamed.
Okay.
Right now you ice for 5 or 10 minutes just post adjustment, and then start getting into a routine. Ice in the morning, ice in the evening, and if you need to take time throughout the day to ice, start getting religious about icing. And as you get adjusted and ice, and we start getting you into traction and doing functional movement, you'll start to get better.
Awesome.
So that's yours.
Thank you.
You're welcome. So like even bending over, is this your phone?
Yeah.
Okay, so bending to get it, yeah, you can squat like that. And then even better, what we'll be teaching you is hip hinging and doing more like a deadlift.
Oh, okay. So like, just using my hips.
Kind of, but
Instead of going like.
yes, but don't be afraid to also bend the knees as you drive your pelvis back. Yeah, good. Yeah, and this is easy for you since you're an athlete. I mean, this is stuff that just comes naturally because the hip hinge is a athletic position. It's a jumping position.
Yeah, I was never a jumper, but it was definitely.
But I mean, if you go to jump, what do? You go, and you jump, right? So.
I think my biggest problem is that like when I do squats, I was always taught in high school, this is definitely not how you're supposed to do it, but like butt out, chest forward. So you're like this. So like now that we're correcting my squats, it's hard because it's like I have that curve in my back. So I have to find like a happy medium without.
Sure. And squats are so individualized to someone's torso height, their leg length height, the anatomy of their pelvis. So some of those like gross instructions that they give you is better than having kids do a squat and rounding their back while they do it. So they say stick your butt out and chest forward just to counterbalance. It's a good starting point, but it has to be customized for each person. So well, let's do this. Let's have you get changed.
Okay. I'm gonna go put on like my actual scrubs.
Cool.
I brought my
All right.
to change into.
All right. Well, good job.
Thank you.
All right, there you have it. That's the workup of Emily. This is her first time ever getting adjusted. She's a new team member for us. We wanted to make sure she was taken care of. Comment, let us know what you like about this video or what you want to see more of. Let us know if you've ever had a problem like this before, if you were an athlete and you've had headaches and low back pain and you've just been dealing with it, especially if you're in your 20s or 30s, or worse yet, you're in your 50s or 60s and this was you 30 years ago. Let us know and follow us. Check out all of our upcoming videos. When it comes to the health of you and your family, results matter most.